Next is, I'd like to introduce Kristy Knight. Kristy's a pediatric audiologist and associate professor in the Department of Pediatrics at Doernbecher Children's Hospital in Portland, Oregon. She's been a member of the Children's Oncology Group Auditory Late Effects Committee since 2008 and has served as a study audiologist for the COG's clinical trials. She's a member of the International Late Effects of Childhood Cancer Guideline Harmonization Group, IGHG, which is developing international surveillance recommendations for childhood, adolescent, and young adult cancer survivors. Kristy is going to offer us a clinical overview of the chemotherapy-induced hearing loss. Kristy?
Thank you. It's a great pleasure to be here to talk about treatment-induced hearing loss in childhood cancer survivors. I don't have any relevant financial relationships or conflicts of interest to disclose. My goals for this talk are to just review the cancer therapies that are potentially ototoxic and can cause hearing loss, to discuss a little bit of the mechanisms of why hearing loss occurs, to summarize the prevalence of hearing loss related to cancer treatment in children, and review the impact of hearing loss, and lastly discuss the current strategies that we have available for mitigating and managing hearing loss. Certain medications or chemicals are ototoxic, which means they have the potential to cause damage to the inner ear that results in hearing loss, tinnitus, and balance dysfunction. The cancer therapies that are potentially ototoxic are the platinum chemotherapy drugs, cisplatin and carboplatin, and cranial radiation that involves the inner ear. Approximately 1/3 of children with cancer will receive a platinum analog as their first or second-line treatment. In the United States, approximately 5,000 children receive platinum chemotherapy annually. Several pediatric cancers are typically treated with platinum, and these include brain and central nervous system cancers, neuroblastoma, hepatoblastoma, osteosarcoma, germ cell tumor, and retinoblastoma. When we look at all diagnoses and treatment plans combined, approximately 50 to 60% of children treated with cisplatin and 5 to 20% of those treated with carboplatin acquire some degree of irreversible hearing loss. The incidence increases to 80 to 90% in those who receive cisplatin and myeloablative carboplatin. The prevalence of hearing loss from radiation is reported at 10 to 14%, and when a child is treated with cranial radiation and cisplatin, the rate of hearing loss is over 80%. One significant risk factor for treatment-induced ototoxicity is the age at the time of diagnosis and treatment. Children who are 5 years and younger are at 21 times the risk for developing hearing loss compared to adolescents. Other risk factors include the platinum dose, both the individual dose per course and the total dose, having cranial radiation before cisplatin treatment, the use of more than one ototoxic medication during treatment, and genetic differences. The time of onset of the hearing loss is variable, but it can occur as early as the first or second cisplatin cycle. Ototoxicity typically occurs in both ears and is permanent. The hearing loss typically first occurs for the high-frequency sounds, and it increases in degree and spreads to affect lower frequencies as treatment continues. The figure on the right shows serial hearing evaluations in an 8-year-old during treatment for medulloblastoma. The audiogram displays sound frequencies in hertz across the top. And the sound frequencies are low pitch on the left side of the graph, going to high pitches at the right side. And the intensity of sounds is displayed on the vertical axis from very soft levels of sound at the top to loud at the bottom. Each point represents the loudness level that was required for the child to just begin to perceive that sound frequency. And normal hearing is thresholds that are 20 decibels or better. So if all of those marks are at 20 or above 20, that's normal hearing. In this child, high-frequency hearing loss occurred after the second cisplatin cycle at a cumulative dose of 150 milligrams per meter squared, and you can see that it worsened with each subsequent treatment until treatment was completed. The hearing loss from platinum results from damage to the sensory hair cells within the cochlea. Cisplatin and carboplatin enter the cochlear fluids from the blood, and they're taken up by several cells within the inner ear, and it appears that cisplatin is retained in the cochlea for months to years. The fluids inside the inner ear have to maintain an electrical charge, which is called the endocochlear potential, to allow the sensory cells to change sound vibrations into electrical signals that the brain can receive. And platinum impairs the function of the cells that maintain this electrical charge. The cochlear hair cells are permanently damaged by the loss of the endocochlear potential, generation of reactive oxygen species, and antioxidant defense mechanisms are also depleted. And damage begins at the opening of the cochlea or the base where high-frequency sounds are processed, and it progresses towards the end of the cochlea or the apex where low-frequency sounds are encoded. And this is why we see hearing loss starting in the high-frequency range and then progressing to the lower frequencies. And this is an end-of-treatment audiogram that includes letters to show the average frequency and loudness of the speech sounds. And the red circles are a child's hearing levels. The sounds that are below the circles, or the letters below the circles, are sounds that are heard well, while those that are above the circles are sounds that are likely not perceived. We know that children who are in the process of acquiring language require audibility to 8,000 hertz, so across the entire frequency range, to correctly perceive and discriminate the sounds of speech. When the high frequencies are lost, the speech sounds such as F, S, T, K, H, P, and SH are too soft to be heard, and speech becomes difficult to understand, especially when listening to speech from a distance or speech in noise. One thing that we know about children's language development is much of their language development occurs by overhearing the conversations of others, and that requires good distance hearing. As a result of the hearing loss, greater cognitive effort is needed to decode speech. And due to the increased cognitive load, less resources are available for comprehension and memory. Treatment-induced hearing loss can worsen in the years after therapy is completed. Studies have reported progressive hearing loss in 20 to 50% of patients who receive platinum chemotherapy and/or radiation. Hearing loss has possible impacts on learning and cognition. In a group of 137 neuroblastoma survivors who were an average of 11 years post-diagnosis, survivors with hearing loss had twice the rate of parent-reported problems with reading, math, attention, learning disability, or special education needs. The survivors with hearing loss reported poorer quality of life and poorer educational functioning compared to those without hearing loss. In another study of 165 medulloblastoma survivors, 5 years after diagnosis, severe hearing loss was independently associated with declines in cognition and reading ability. There are also long-term potential socioeconomic impacts of treatment-induced hearing loss. In a study of 226 childhood cancer survivors who received cisplatin for non-CNS tumors, those with severe hearing loss were at twice the risk for non-independent living, not graduating from high school, or not being employed compared to survivors without severe hearing loss. The current strategies that we have for mitigating ototoxicity include continuing treatment in spite of worsening hearing loss, as is the case for hepatoblastoma, or having the option to modify or change treatment once hearing loss has occurred to prevent further hearing loss, as is the case for medulloblastoma. This results in the choice between preserving hearing and quality of life versus possible compromise of treatment and chance for cure. Once hearing loss occurs, rehabilitation often includes the use of hearing technology such as hearing aids, remote microphone technology, FM systems, or cochlear implants in the case of severe to profound hearing loss. Treatment for hearing loss is not inexpensive. In the United States, the average cost for a mid-level pair of hearing aids is $4,600, and they have an expected lifespan of 5 to 6 years and may not be covered by insurance. There are also educational supports and modifications that are often recommended, and these include things like seating accommodations, acoustic modifications to the classroom to reduce background noise and reverberation, special education services, tutoring, classroom note takers, and the use of communication strategies such as always facing the student when speaking, getting closer. I'd like to conclude that, the one other thing I wanted to mention is that survivors with hearing loss require regular hearing evaluations to monitor for progression of hearing loss over time, And we also want to ensure that their hearing devices are working optimally since they're relying on them for communication. It's very important that individuals avoid future ototoxic medications if possible, and that they are very cautious about exposure to noise and use hearing protection whenever exposure can't be avoided. Hearing loss is a permanent lifetime disability that in children has ramifications for speech and language development, learning, social development, employment, and lifetime earnings. The current methods for addressing hearing loss are not optimal, and I'm excited that we're in a time when reduction or prevention of treatment-induced hearing loss is a possibility. Thank you.